So I have a case of 67-year-old morbidly obese male, resident of Himachal Pradesh, with a past medical history of mid-RCA CTO diagnosed outside in 2022, and that was previously attempted plasty, but patient was on medical management. So he came to me with a complaint of angina on exertion class 2 and dyspnea on exertion class 2 for the last 6 months, and transthoracic echo showed the RCA hypokinesia 45%. So this is the angiogram showing the fairly normal left system with the minimum collaterals to the RCA. This is the RCA CTO assessment. Proximal cap, it was blunt with the side branch at the cap, and the length of the CTO was 10 mm with good distal landing zone. So my plan of action was antegrade wiring. So I decided to take right femoral approach with 7 French JR 3.5, and the first choice of wire was Pilot 200 with fine cross. So as I tried to navigate the wire, there was perforation. So I did balloon tamponade with 2.5 12 mm balloon for almost 3 to 5 minutes. Patient was hemodynamically stable. There was minimal pericardial effusion. I took a breath and I decided to navigate further. And I changed my wire from Pilot 200 to Gaia 3rd. I was successful in hitting the proximal cap. As I was trying to navigate further, I could find the resistance, so I took the help of 6 French guide liner. And finally, I crossed the CTO. Wire was parked in distal lumen. All the way, I was my second-hand operator. He was taking care of echo. There was minimal pericardial effusion. Patient was hemodynamically okay. Sequential pre-dilatation was done with 1.2, 2, and 2.5 into 15 mm balloon. Patient hemodynamics were all okay altogether during the procedure. Finally, I decided to deploy the stent. Distally 2.5 into 36 des, mid 3 into 44, and osteoproximally 3.5 32 mm drug-eluting stent. Post-dilatation was 3 into 12 mm NC balloon, mid to distally, and 3.75 into 12 mm NC balloon proximal to mid. And this was my final result. TIMI 3 flow with minimal pericardial effusion. 12 hours after the procedure, patient started complaining of chest pain, falling BP. Pericardial effusion slightly increased to mild pericardial effusion. Check shoot was taken, but there was no increase in perforation. Patient was hemodynamically okay. Thereafter, check angio again at 1 month was done. Perforation sealed, and it was well-flowing RCA stent. It's been 8 months of the procedure, and my patient is doing very fine, hemodynamically stable. So my take-home message is, balloon tamponade is the foremost step in the perforation protocol. Challenging wiring, antegrade wiring is challenging, especially if there is a side branch at the origin of proximal stump. There's always a risk of perforation. Large vessel perforation during CTO crossing coils can be of help for hemostasis achieving. There's no role of covered stent as there was no access of wire in true lumen distally. Whenever there is a side branch at the proximal cap, take the help of dual lumen microcatheter or single lumen microcatheter with a guide wire with a large secondary bend could also be taken, or angulated microcatheter can also be of help. Thank you.
Could you go back to your first pictures? Great case and good for persevering. And again, it's very easy to be. But one of the things, so see when you've got this type of setup where you've got a branch, an ambiguity at the proximal cap, and you've got a GR4 guide, if you had put a 2020 balloon from the side branch into the main vessel and pinned your microcatheter, that gives you increased support. So if you go forward a couple of views,
okay.
See when you've got your balloon up to control the perforation?
Okay.
Go forward.
Okay.
Go forward. Okay, so is it the next one? Next view, next one. Yeah. So go back ones. Yes, when you had your 2.5 balloon up, controlling that perforation, I would have left it there, bring the microcatheter alongside, and it would continue to seal the perforation and allow you to open the vessel. And then the other thing is, if you look at the proximal vessel versus the distal vessel, when you open these vessels, if you do imaging, the vessel distally is really small relative, and the right should be the same size the whole way. I would just have ballooned it open and not put any stents in, and that would allow you to give protamine at the end of the case and turn off your heparin. But because you have stents in, you don't want to turn off the protamine. So the pericardial effusion you get is like a bruise. You've damaged the vessel and it continues to ooze. So if you can turn off your heparin with protamine at the end of the case, you're less likely to get these pericardial effusions.
Okay.
I think fortune favors the brave, but you were rather brave because I actually was very surprised in your next slide after the perforation. Once you said that the pericardial, a few hours later, the blood pressure started to drop, the pericardial effusion started to increase. I would have definitely skipped a beat myself because what is happening here? What is happening? So I think in every perforation, the universal algorithm for treating a perforation and basic principles must be adhered to. I mean, the same point was made by Colm that you, firstly, when accessing, I found that your wire escalation was a little, shall I say, risky or aggressive. Don't call it risky, but it was a little aggressive. But all the same, you could have, suppose this had increased, and then you had 3 stents in, you would have been up shit creek without a paddle.
It was a lucky day, actually.
Yeah, whatever it is.
Fortune favors the brave. One point I want to make. She make repeated injections actually because there was no contralateral catheters. She could have used the contralateral injections to shoot the distal artery.
Yeah, but the good thing is she did not inject too much. I was noticing that.
The thing is that hematoma increased in the, like there was a lot of contrast staining. That's mainly because of injections. So you could have used the contralateral injections for delineating the distal artery and
Actually, in the first view, the distal artery, I could appreciate and there was an antegrade flow. So I didn't think of giving the.
That's the intracoronary
flow
collateral.
is going through what? Is it going through loose tissue, what we call microchannels? Is it going through a branch which is supplying it retrograde? It's sometimes difficult to guess. So having a contralateral control is one of the basic principles of doing
Right.
CTO-PCI.
But
I know that there are many guys who believe in single catheter operations today, but yeah, Carl.
I mean, the problem I see here is you cause a perforation, and the perforation is not that small, because it will depend on your further management if it becomes bigger or not. Now, imagine you cross in the next 3 minutes. What you do, you dilate, you might increase the pressure and also the extent of the perforation. You put a stent, and then you have a pericardial effusion. And now you have to reverse your heparin. So you are bringing yourself into really deep trouble. So in my opinion, in this kind of case, with that perforation, you should also consider to stop and postpone the procedure for another day. Just as a message for the younger physicians, because sometimes you can bring yourself into more trouble by insisting.
I always, with the smallest of bleed, I stop the procedure.
Yeah, but she's making a point here. You know, I understand. I would also probably stop, but she's making a point that she felt that number one, her perforation was under control. Number two, she also felt that she now has access to the distal RCA. But I would again be a little careful because I may need to reverse. I would like to reverse the heparin. I did not know what the ACT was at that time, and use protamine for that reversal. So I don't want metal. So very clearly, I don't want metal at that time. So I would probably do.
But just in a gentle point, if you look at the proximal right coronary artery, here's 4, and the distal vessel looks 2.5, and that's because it's underfilled. So I'm not putting stents in these at any stage. I'm using DCBs. I'm bringing them back at 6 weeks. So even if I had opened this vessel without a perforation, I would not be putting stents in because of that mismatch. So the vessel down at 8 o'clock is underfilled from collateral circulation. If you balloon it open with good flow and bring them back at 8 weeks, you may not need any stent in, or if you do put a stent in, it's a much bigger
And also
stent
that balloon will tamponade any perforation which is happening. So it'll help seal your perforation.
Can you show the next shoot? That hematoma, can you show?
Sorry?
Can you
So
go to the next slide?
one counterpoint. A lot of times when we do these antegrade CTOs, your wire goes here and there.
Next.
And you get these small micro perforations. In fact, one of the best ways to seal this perforation is to finish the procedure and put a stent. But this page, no, I'm not saying in this case. I'm just saying it because that's another approach. Unfortunately for her, when she was doing it, actually the hematoma became big. Luckily, it did not cause anything. Sometimes a localized hematoma can also compress on the coronary artery and can cause further complications. But for her,
You can see that it has continued to ooze, only it has not gone into the pericardial space at this time, because the contrast which is seen external to the vessel has definitely become scary, and it is quite horrific actually.
Such large hematomas are cause of dry tamponade, and they are very difficult to manage actually, frankly speaking. You cannot train them also.
And when we open up the RCA in this situation, the retrograde collaterals may increase the leak even more. It's better to quit it, at that time it is the best strategy to
I would say that it is better to tamponade this with a balloon, wait for the result, not put in a definite stent or that index procedure. That's what I would like. Yep.
The second time, can you show that angio when the patient became hypotensive? There is still a leak which is there, and it would be because the patient had a little bit of hemodynamic compromise. I would treat that because it is like living on fate.
But the point is, I actually was very surprised that between the second and the third shoot, there was nothing, because there was happiness in the third shoot. By second shoot, I was saying, oops. First shoot, that there was a mild increase.
There is still some perforation which is there. Then this is the
But
CG at one
there
point.
was no increase in the perforation.
Did you give any protamine at this time?
No, I didn't give.
I
didn't
think
give.
fortune favors the brave.
I didn't give.
There was no balloon to tamponade at that.
No, but would everybody leave this, or what would everybody do? A quick comment. Like there's a little.
So let's take a vote on this.
Little perf is still there.
If your blood pressure had started to fall 12 hours later with some increase in pericardial effusion, what would you do?
I'll prolong balloon inflation, I'll do it again.
See, I think the drop in blood pressure has something to do with the pericardial effusion, but it's not a pericardial tamponade. Very
Yes.
often, the main
Yes.
reason.
It was not tamponade.
The main
It was
reason-
just a mild increase in the effusion.
So if we understand tamponade physiology,
No.
if we understand tamponade physiology, that is a counterintuitive statement. Because
Can I
if there
explain?
Okay.
Can I explain? So, very often, if you perforate a vessel and you have some blood in the pericardium, but it's not a tamponade, very often the patient becomes vagal because they feel the
vasovagal only.
pericardial, and then they don't need a balloon to seal the things. The first thing they need is volume, a bit of water, and atropine, and then very often they stabilize without further ado.
And these,
Yes.
and these are,
It
these
was
are not, these are
vasovagal.
not, these are not massive pericardial effusions. They're hard to hit, so they're often about half a centimeter. So you're trying to get into pericardial space, which is a very small target. It's different if it's a 3 centimeter pericardial.
But this is after
effusion,
12 hours,
you know.
not acutely.
So
Not
I
acute,
think
this
you
is
tr-
after 12
I think you
hours.
try and sit on these as much as you can. You give them protamine to turn off the heparin. You give them lots of fluid.
This
and
was
you
12
try-
hours after the procedure.
All right. I think
Okay.
our time is
Thank
up.
you.
But well done. Fortune favors the brave.
Sir,
Indian ladies are braver than Indian men.
Definitely. Definitely. Big hand to that.
Sir, just for learning purpose, may I ask one thing? How to differentiate between ventricular wall staining versus the pericardial staining?
Yeah, so I think this is a periadventitial hematoma. And then, as I say, as it oozes and you end up with a pericardial effusion, because we do an echo at the end of the case and there's no pericardial effusion. And then 2 hours later in recovery, they drop their pressure. So I have a very, very, very low threshold for turning off heparin. I have a very low threshold for stopping. Once I see pericardial perforations, very low threshold for stopping. very low threshold for not putting in stent.